Hey all, welcome back to the Real Life Pharmacology podcast today. I've got a bit of a special episode for you here. This was per request of someone. Just wanted to know a little bit more about drug interactions, so that's definitely what I'm going to cover today. If you would, definitely go to reallifepharmacology.com, get your free 31-page PDF on the top 200 drugs. If you're taking pharmacology classes or if you're out practicing in the real world, it's a great refresher. It's some of the things that I've come across in practice, as well as things that I've seen on board exams as well as pharmacology exams. So definitely stuff that you should probably know and have memorized if you're studying pharmacology. So again, simply an email will get you access to that at reallifepharmacology.com. It's our top 200 study guide. All right, so let's get into the podcast today, which I said is going to be a little bit different. I'm going to go over my top 10 drug interactions surrounding antihypertensive medications. So those commonly used blood pressure medications. Wanted to give you guys some things to look out for in practice as far as drug interactions go. And then, of course, a lot of these will show up on board exams as well. So I've got them in no particular order. Some are maybe less common but more severe, and some are maybe more common but less severe. But let's go. So ACE inhibitors, diuretics, and NSAIDs. I've heard this called kind of a triple no-no. Ideally, we should avoid this 3-drug combination if possible. The reason being mechanistically, if you think about the way ACEs and NSAIDs affect kind of that flow into the kidney, and if you want to go back and listen to the mechanics of that, you certainly can on previous podcasts where I discuss some of the NSAIDs and ACE inhibitors. But those can basically impact the flow on the kidney, reduce the flow on the kidney. Diuretics can dehydrate. That reduces flow to the kidney. And ultimately, we can end up in an acute renal failure situation. So definitely pay attention to kind of that triad of medications, because it can lead to some issues. If you absolutely have a patient on it, you better be very closely monitoring their renal function for sure. All right, next one, I'm going to stick on the ACE inhibitors and the ARBs. Potassium. So we all know those drugs can raise potassium levels, but there are many medications that can add to that effect. I have personally seen an issue with trimethoprim contributing to a severe life-threatening hyperkalemia situation in a patient already on an ACE inhibitor. So this can definitely happen. Other medications to think about, obviously spironolactone, which is another blood pressure reducing medication, a potassium sparing diuretic. Cyclosporin's one that's not commonly used, but some of those immunosuppressives can raise potassium levels. So those would be important as well to look out for. Keeping on the ACE inhibitors and ARBs for now, I'm going to lump this one together, but diuretics and ACEs and ARBs can both raise lithium concentrations. Now, lithium isn't commonly used. It's used for bipolar disorder, but if we have, it is a narrow therapeutic index medication, so if we add an ACE inhibitor or a diuretic on top of that, a patient taking that who's maybe stable, well, now those concentrations of lithium can go up and we can potentially cause some lithium toxicity there. So definitely a good one to remember in our bipolar patients. If we're trying to manage blood pressure, we've got to be a little bit careful with those ACEs and ARBs as well as diuretics there. Nitrates, not a commonly used medication strictly for blood pressure. Typically, we're using these for angina, chest pain, but it definitely is a very, very important interaction. Definitely one I've seen come up on board exams quite a bit. You've got to remember the PDE5 inhibitors can cause profound hypotension, drop in blood pressure. So those are your erectile dysfunction drugs. Also can be used for pulmonary hypertension, but a drug like sildenafil or tadalafil, for example, there. With the theme of this podcast, I would definitely strongly encourage you to go check out meded101.com. Check out the resource tab up top of the home page and click on free stuff. I've got an 18-page PDF on really common drug interactions that show up in practice, as well as on board exams. So definitely a no-brainer to go snag that. It'll be a great little review for you, or if you're just starting to learn medications, a great place to start if you're looking at potentially memorizing drug interactions. So simply subscribing to the Meded 101 blog with the email, that will get you access to that 18-page PDF on the top drug interactions. Example blog posts that I've had recently, if you like clinical pharmacy related things, comparing ibuprofen versus naproxen, Parkinson's medication management, why patients are so fussy about the timing of their meds. Also give a rundown of my important takeaways from the 2024 ADA guidelines. So those are just some of the examples of the recent blog posts that we've had at meded101.com. So simply subscribing there, you can check out the blog as well. But again, under the resources tab, click on that free stuff and you'll find your way to subscribe. Next, we have amlodipine, very, very commonly used blood pressure medication. There aren't a tremendous amount of drug interactions with amlodipine. It does inhibit CYP3A4, but it's a pretty mild inhibitor of CYP3A4. So with that said, the one drug interaction I've probably seen come up the most is with simvastatin. It can raise concentrations of this statin medication for cholesterol. And so that's definitely something to look out for there. So you ultimately, we can potentially try to switch to an alternative statin. Rosuvastatin should interact, for example, a little bit less. Or we have to watch the dose of simvastatin and probably not push it too much there. Next, we have sacubitril valsartan in combination with ACE inhibitors. Sacubitril valsartan is Entresto is the brand name there. So there needs to be a 36-hour washout period when we're switching somebody from an ACE inhibitor to sacubitril valsartan. The reason for that is angioedema. Again, definitely another one that'll come up in practice potentially and on board exams for sure. Diuretics and aminoglycosides. So again, aminoglycosides not used terribly often, pretty much primarily used in a healthcare type setting, a hospital type situation. Occasionally I have seen it outpatient. But we've really got to pay attention to renal function here, okay? So acute renal failure is a big issue. The other issue primarily with loop diuretics, maybe more so than like thiazide diuretics, we also can have hearing impairment and cause ototoxicity as well. So definitely a drug interaction to pay attention there too as well. Let's talk beta blockers a little bit. So beta blockers, I definitely think about some of those medications that can lower pulse. And, probably the obvious one is the calcium channel blockers of diltiazem or verapamil. Those can kind of have those additive effects. But we've got some medications for dementia. So donepezil, for example, rivastigmine's another example. Those medications can actually cause bradycardia as well. So adding them on top of a beta blocker can definitely drop that. In addition, kind of a bonus drug interaction here, you've got to remember that beta blockers can sometimes blunt the effects of beta agonists. So if we're trying to treat COPD, asthma, there is that potential, particularly with non-selective agents more so, such as propranolol, where we're going to blunt the effectiveness of that beta agonist. And then, of course, with beta blockers, the last thing, or one of the other major things that I've certainly seen come up on exams and in practice as well, is it can blunt the signs and symptoms of hypoglycemia, particularly patients on sulfonylureas and insulin. They're probably a little bit more at risk for hypoglycemia in our diabetes patients, but that is a potential interaction there to look out for. Let's mention diltiazem, verapamil a little bit. Diltiazem particularly probably is a little bit stronger inhibitor of CYP3A4. Again, these meds aren't used incredibly often for their blood pressure lowering effects. Often there's a compelling indication like atrial fibrillation or certain types of headaches, for example. But I do want to mention them for completeness here. So diltiazem having some of those interactions, being a CYP3A4 inhibitor, it can raise the concentrations of numerous medications, anything from a benzodiazepine like alprazolam, budesonide's an example there, carbamazepine, seizure medication, or a bipolar medication, mood stabilizing type medication, fentanyl, some statins. So there's lots of drugs that are broken down by CYP3A4, and diltiazem can definitely raise those concentrations. So I definitely think it's a noteworthy interaction to mention in the antihypertensive section here. And then last, but not least, I guess, you've got to remember other medications that lower blood pressure. So I alluded to PDE5 inhibitors. So when we add that on top of other medications that can drop blood pressure, that can be an issue if we drop that blood pressure too low. SGLT2 inhibitors, those newer diabetes medications, those can drop blood pressure a little bit. Usually, probably not clinically significant, but it is something to definitely pay attention to. Some of the Parkinson's medications have some orthostasis risk. Carbidopa-levodopa, for example, there. Some of the antipsychotics can cause some orthostasis and drop in blood pressure. So definitely pay attention to that when we're starting new medications, making changes, that we could have those additive effects in dropping blood pressure. All right, well, I want to thank you for listening. Please support the sponsor, meded101.com/store. We've got growing list of resources for pharmacist board certification like NAPLEX, BCPS, ambulatory care, BCMTMS, and much, much more. So go check that out at meded101.com/store, STORE. Also, if you're a nurse practitioner, med student, anyone else, we've got a bunch of resources at meded101.com/store as well. Amazon books, for example, on drug interactions like I spoke about today, for example. Your support there greatly helps this podcast keep going, and obviously keeps it free and available for all to benefit from. If you enjoyed this podcast, do us a huge favor, leave us a rating review. And as always, you can reach out to me at mededucation101@gmail.com. Send me suggestions, ideas, thoughts on podcasts, as well as blog posts, ideas too, on meded101.com. I'm going to sign off for today. Thank you so much for listening. Take care and have a great rest of your day.